Says no. All right. So tuberculosis, let me backtrack. COPD is a chronic condition. Pneumonia is an acute condition. Tuberculosis has both acute and chronic elements to it. Tuberculosis, by definition, is simply somebody has been infected by this organism, Mycobacterium tuberculosis. It may occur in their lungs, and we call that pulmonary TB. Basically, when you hear somebody talk about TB, probably 99% they're talking about TB in a person's lung. However, that organism can travel through the lymph system to other organs in the body, and so you can have TB bacillus growing in a person's liver and some of their other vital organs. Okay? How big a problem is it? Well, it's estimated that more than 10 million new cases yearly throughout the world are discovered or occur. Estimated about 1.8 million people died in relationship to TB just a few years ago. So just even as soon ago as 4 to 5 years ago. That's a lot of people dying in a single year from anything. It's estimated that about a third of the world population is currently infected with the organism, even though they may or may not be showing signs and symptoms yet. And unfortunately, because of some issues we'll talk about, there are multiple drug-resistant strains of the organism that now exists. So what's the etiology of this disease? Well, that inhaled Mycobacterium bacillus reaches the alveoli, and because that organism is very, very small, 1 to 5 microns, it is actively airborne anytime the person is exhaling. So whether they're coughing, talking, laughing, sneezing, singing, doesn't matter. They're spewing that little tiny organism out into the air. Nice thing is that if we only have brief exposure to these individuals, it usually, a healthy immune system will prevent infection. Because the organism must resist the body's natural defense mechanisms in order to penetrate lung tissue before an active TB infection occurs. So what are the risk factors? Who's at risk for this? Well, some of those same people we keep talking about, those immunocompromised people, people who have HIV, people who are on cancer treatments, people who are malnourished. And by malnourished, it could be related to poverty, could be alcohol abuse, could be drug abuse, illicit drug abuse, where they're just not meeting their nutritional state and their immune system is not working right. People who are frequently in contact with the medically underserved. And by medically underserved, I've listed some examples. So low-income individuals, homeless people, people who come from outside our country, and then drug abusers. And just like pneumonia, those who are confined in a residential facility or institution. So in this case, it would be not just nursing homes, but even people within prisons would be an example of that as well. And then lastly, those who are exposed to it as a result of their job. So that includes all of us. As healthcare workers and nurses, or future nurses as well, you will be exposed to it. So let's understand what it does and how it does what it does. So first off, the individual has to inhale that TB bacillus from the air. Then an inflammatory process develops a pneumonia-like process like what we just described. Only in this situation, when the white blood cells consume the bacillus, it's not always successful in killing them the way it does a lot of the other bacteria that white blood cells consume. And so all of a sudden, the white blood cells who are infected by these carry that throughout the lymph system and to other parts of their body. So in some ways, the TB bacillus acts a whole lot like the HIV virus. It lives within our cells and uses it to its advantage. That's what the TB bacillus does as well. but a slightly different process. The primary infection site, so its port of entry into those lungs, may cause active or what we call dormant TB. And we'll separate those out in the next slide for you. Active TB, there's a process that occurs where the tissues begin to be consumed by the bacillus. That's what bacteria do. Remember, they don't have a digestive system. They secrete enzymes to their environment, creating a chemical process around them, and then they suck in the chemicals and good stuff they want from their environment. Well, when they do that with our body's tissues, it causes the tissues to die and be damaged. That's what sets off an inflammatory process with any kind of infection. And so as that tissue begins to die, it produces these cheese-filled cavities. Doesn't that sound amazing? Cottage cheese-filled cavities, perhaps, of TB bacillus, dead white blood cells, and dead lung tissue. It creates these pockets of goop, if you will, in your lungs, in the patient's lungs, hopefully not your lungs. And that goop liquefies as the white blood cells continue to work on it. It liquefies, drains to the airways, and is coughed out into the environment. And it leaves a cavity, an air-filled cavity in the lungs. Dormant TB, on the other hand, our body forms scar tissue, granulation tissue around those invading organisms and produces what we call a calcified lesion. It basically forms a little prison cell, if you will, that we call gone tubercles that wall off and contain the bacillus to keep it from eating more of your tissue or the patient's tissue. And it can keep it walled off in that area for many years. And the patient will remain asymptomatic, although they are actually infected with the organism. They have these little prisons, if you will, throughout their lungs. Regardless of whether it's active or dormant, our body develops an allergic response, and specifically, going back to that chapter you just had a few weeks ago, a cell-mediated response to that bacillus, meaning it pre-programs some of your white blood cells to recognize any escaping bacillus for the rest of your life. Okay? So that if one escapes out of a gone tubercle and starts to create havoc, it can arrest and kill, or whatever it needs to, shoot on sight. Okay? It can eliminate it. That's what it means by cell-mediated. It is pre-programmed to recognize that bacillus from that point forward, or the proteins that it might leave behind if it's consuming things in its wake. It takes 2 to 6 weeks for our body to be equipped for this, so you got to train some security guards, if you will. Train them to recognize those little guys. It occurs in all of the person's body cells, not just the cells of their lungs. And again, if they see a bacillus that's out and about, it inhibits the growth of that bacillus, and it prevents active TB from developing. And as I said, it will last the rest of that person's life. Okay? Now, I don't remember if I mentioned this later, so I'm going to mention it now. It is this process that allows us to do skin testing, the Mantoux test, to determine if a person has been exposed to TB. The reaction created on that person's arm in response to us putting a TB protein, we call it PPD, purified protein derivative of the TB bacillus, putting that inside a person's skin allows that person's body to recognize and attack if indeed it has been trained to do so. If it does not respond aggressively like that, that person has never seen that bacillus before. It's a brand new experience. And so that person has not got the bacillus in their body. Okay?
Mr. Baird,
Yes.
in the HIV chapter, it talked about energy when
Yes.
people, are so compromised that they might have been exposed, but they don't react to the PPD.
Very good. Absolutely. And what Mrs. Martinez is talking about is a word spelled Anergy. Energy or energy, okay? It simply means the immune response is dampened or maybe not even existent because their immune system does not respond the way it should. So in those people, we interpret their results differently. So I'm kind of covering a little bit of stuff I think I covered in the prep work, but basically, if their response is even 5 millimeters in diameter, it's still considered positive for those people. Whereas for a healthy individual, it's 10. Okay, you have to have a bigger response, all right?
How do you spell it?
Energy or energy is the body's inability to respond to that exposure because the immune system is compromised, like through HIV, okay? So it's misleading, if you will. All right, so signs and symptoms. How do we know these people have it or don't? Well, dormant TB may be completely asymptomatic, and the only way we find it is through that skin testing. So those annual TB tests that we have you do is how we identify if any of us have been exposed. Chest X-ray may show the gone tubercles or those air-filled cavities as well. The client will often have a cough. It may be productive or it may be non-productive. Typically, if it is productive, it is hemoptic. They often have a tremendous lack of energy, even more so perhaps than someone with just regular pneumonia. They have anorexia and weight loss. They lose their appetite and desire to eat, and they often become what we call cachexic, meaning severely malnourished. They have a low-grade fever, as opposed to a higher-grade fever you might see in some of the other pneumonias. They have chills, and then they have something called night sweats, where literally they wake up during the middle of the night, many times extremely anxious, and they are covered in sweat. They're severely diaphoretic and may not be able to liken it to anything other than, this is weird, this is freaking me out. They often are dyspneic. I mentioned hemoptysis already. They may have that pleurisy feeling like we talked about with other types of pneumonia. And they may have actual changes in their respiratory sounds depending on whether they're active or dormant. Okay? So what happens in the long runs of these people? Well, some of the same things. They too may develop respiratory failure as a result of it, or their other organs may become infected and dysfunctional as well. Okay? The next few slides I covered extensively in the prep work. So just recognize those 5 tests are ways that we can identify, so ways that we can screen. The first one is a screening test. The other ones are diagnostic in nature, okay? I've given you that information on these slides, but if you want it explained in detail, just review the prep work for me. This acid-fast bacillus smear, I just want to touch base on that one just a little bit, because basically this is how we determine whether that person is active TB or dormant TB. Some of those other tests will identify that they have an infection, but not necessarily whether it's active. If a patient is coughing up the bacillus and we can see it in their sputum through what we call an AFB smear, and then we can take that sputum and grow out that bacillus over the next 4 to 6 weeks, that person has active TB. They have caseation occurring and goop in their lungs that makes them contagious. I'm sorry, my ears are wanting to pop for some reason. I don't know what's happening. Chest X-ray, again, we may see chronic issues or something acute going on. So the gone tubercles, for example, being the chronic. And then liver function tests. We're about to talk about drugs. Liver function tests Just like we mentioned cardiac enzymes before, liver function tests are a measurement of those enzymes that the liver releases when tissue is damaged. And so we're going to talk about drugs and how we treat TB, and virtually all of them have the potential to damage that person's liver. So we need those baseline liver function tests before we start treating these people. All right, so let's look at some of those things right quick. As I mentioned, there are drug-resistant strains that have developed, and so now what is recommended is a multi-drug approach by the CDC, meaning that we're going to hit it with multiple drugs in order that hopefully the combination or a specific drug given will eliminate that and keep it from spreading further in the community. So the initial phase of treatment typically lasts about 2 months with what we call the 4 first-line meds. And those are listed in a slide at the bottom that we're going to get to in just a moment. And then we switch them to a 4-month, up to 2 years period of time with primarily 2 meds, and those most often being the INH and the RIF. Compliance is our #1 problem in treating TB. And what I mean by that is keeping that patient taking those meds consistently day after day is a problem. And if they don't, then that's how those drug-resistant strains develop. Okay, so cost and the side effects of these drugs is one reason why some patients don't continue. And the client population at greatest risk are not exactly necessarily the most reliable citizens in the community. And so our health departments have developed different initiatives in order to address this client's problem. And first one is providing free meds to anyone who has been diagnosed with active TB. And then free follow-up. And by follow-up, I mean the periodic testing of liver functions and the periodic treatments that have to occur over time. And then the second one is what we call DOT therapy, or directly observed therapy. And that literally means that a healthcare personnel, may or may not be a nurse, but healthcare personnel will observe and administer a client's meds daily for that first 6 months. That includes the homeless, the street people, the people at the local shelter, etc. They literally go out into the community with their bag of medicine and watch that person take their meds every day until that 6 months is over, in order to promote compliance. So what are the things they're giving? Those first 4 meds is what I mentioned a while ago: INH, RIF, pyrazinamide, and ethambutol. Most often they're given in oral form. Some of these drugs are now combination drugs. Some of them are what we call bacteriostatic, meaning they don't eliminate the bacteria, they simply keep it from replicating. Others actually kill the TB bacillus. So by giving a combination of one that's bacteriostatic and bactericidal, you get the best of both worlds. All right, so side effects that kind of encompass all of them is they all have that risk of hepatotoxicity. And we see that that client's liver being damaged when we see their liver enzymes begin to elevate in their blood samples. And so they all have nausea and vomiting. They all affect that client's appetite. They all affect their energy level. And if their liver has been damaged, then they develop jaundice as a result of that. So remember, we see jaundice in the skin, but we also can see it in the sclera of their eyes. So if you've ever seen somebody that looks like the whites of their eyes is kind of yellow tinted, that's jaundice. So some drug-specific side effects. RIF has this interesting phenomenon where it turns the person's body fluids orange. Urine, sweat, saliva, sputum, tears. It even stains their contact lenses. It also causes that nausea and vomiting, that GI upset, and can damage that person's kidneys, not just their liver. Pyrazinamide may cause gout, Gout is the deposit of uric acid crystals in the joints, especially of the feet, is the most common place, making it very painful for the person to walk. Ethambutol may cause damage to the eyes, causing various types of visual changes. INH may cause damage to the nerves, creating what we talked about, diabetic neuropathy, creating that same sensation for these people, but they don't have diabetes. They have simply an inflammation of those nerves. And so it creates that tingly feeling in their hands and feet. So what does that mean for us? There's those wonderful nursing implications that somebody asked about earlier. Well, make sure that every client understands the importance of completing that drug regimen, not just for themselves, but for the people that are significant to them in their life. Because remember, frequent close contact with a person who has active TB increases the likelihood that the next person will get it as well. So all the people that these people live with need to be tested. Okay? They need to be screened to see if they too need to be treated for active TB. And I think I have that on a different place, but it just came up to my head, so that's where it came out. Monitor those liver function tests. Any patient on any of these meds, we need to check those periodically. In fact, let me look at my time. Nope, don't have time. Yep, I do have time. Yep, I'll tell you a quick story. All right. I'm only going to tell you the story because people tell me they like my stories. And so if you're not one of those, I apologize for that. You have to endure for those people who put that in their evals, all right? So several years ago, just because I've been a nurse a long time, I'm approaching 34 years, all right? So I practiced for 20 of those years. So I have had a TB skin test many, many times, all right? One of those years, and this was probably 15 or 20 years ago when this happened, probably closer to 20 now. My TB skin test had a reaction, and that reaction was a huge red area that was painful and tender. So painful on my arm that literally to do that, to blow on it, would almost take me to my knees. And if you touched it, or if my clothes touched it, I just was berserk. I mean, it just hurt that bad. Well, the infection control nurse looked at it and said, well, this is not a typical response, but perhaps you have been exposed. So they send me to the health department, so the hospital doesn't have to pay for it now, the government does, okay? So we go to the government and say, hey, I'm one of those diseased people, can you help me out? And they say, sure, we'd love to, because we don't want you to spread this. And so they put me on the drugs. I think I started out with INH and RIF. They didn't put me on all four because my chest x-ray showed nothing. There was nothing they could see on the chest x-ray, and because the reaction was so weird, they thought, this is really strange. But if you want, we'll treat you anyway. And I thought, well, sure, because I don't want to spread anything to my patients, and certainly not my wife and kids. And so they drew my liver enzymes, everything was good, and we started down this process. Well, within about 30 days, my liver enzymes had significantly increased, and I think by the second month, we had to take a medication break. We had to actually stop them because my liver was suffering so much harm. Well, long story short, years later, so once you have a positive skin test, because that reaction stays there for the rest of your life, you will always have a positive skin test. But because the infection control nurse really didn't know for sure that it was positive, I always had in the back of my mind, was I ever really positive or not? So I talked with my primary care provider probably 8 or 9 years ago and said, hey, I've got this idea. Would you give me another skin test and see if it turns out positive? I need to confirm whether or not I ever had this in the first place. Lo and behold, no reaction. I had suffered treatment and the consequences for no good reason. So then I had to replay back in my mind, how did this happen in the first place? Well, here's how it happened. The day that I went into our employee health was handled in our ER, okay? So you didn't have a separate room or a separate nurse that's all she did. It was the ER nurses when they were in between patients who would do your TB tests, okay? So I'd gone down there, and there was a nurse who had come back to work there that I had not seen in several years. Close friends with my wife, because my wife's a nurse as well. And so they had been close friends, even been at our house a time or two. And I hadn't seen her, and so we had a lot of catching up to do in those few minutes that she's putting this stuff in my arm. Well, guess what? Sitting right next to the fridge in the refrigerator to the PPD, the stuff for the skin test, is the tetanus toxin. Well, because my immunizations are current, then when my body got tetanus injected into its arm, it responded accordingly. And so I never had the PPD test that year. That was a tetanus that had been injected into my skin because she was talking so aggressively that she did not do her 5 rights 3 times. There you go. All right. So that was free. All right, so other nursing implications. Because RIF can create perhaps more nausea than some of the others, then we can divide the dose in half or tell the client to divide it in half and take it twice a day, but take it with morning breakfast and morning or an evening supper time to minimize some of that. And then INH is the primary one that causes the neuritis. And so the way it does that is it interferes with absorption of vitamin B6. And so if a client is prescribed RIF, they should also take a vitamin B6 supplement. And so when I was prescribed those meds, that was one of the things I also had to do for those 6 months, was take that vitamin B6 supplement. Another thing that INH does that's different is it interacts with food, causing a decreased absorption of that medication. So I've listed 2 specific things that interfere with its absorption. So tyramine and histamine. So I've listed both the consequence if a client taking INH eats something in those parentheses, then they may experience the fluttering in their chest that we call palpitations. They may feel flushed, and their blood pressure may elevate as well. Histamine, on the other hand, they might get a headache, their blood pressure might drop, still going to have some fluttering in their chest, maybe some flushing, sweating, itching, or even a nasty thing called diarrhea. So basically part of our nursing implications is we need to teach patients and give them a list of foods that they need to avoid exposure to if they're taking the INH. So that's an example of how you determine a nursing implication based on what you know rather than what was stated, okay? All right. So some other specific things that deal with nursing care of TB in general is, once again, we're going to do that head to toe assessment with focused respiratory assessment, looking for those signs and symptoms that we talked about, including those vital signs and pulse ox. Then we're going to do that sputum collection, trying to find out if they have active TB or not. We're going to treat those nutritional deficits because they're going to have a hard time overcoming that bacillus if their immune system doesn't have what it needs. And guess what we do for a room assignment? They must have a private room. Even if we have not yet got a confirmed diagnosis of TB, if their symptoms are suggestive that it could be TB, for the sake of every other client or every other visitor and every other staff member in the hospital, they should be placed in a private room with airborne precautions. And remember, airborne precautions mean that every person entering that room needs a fit-tested N95 respirator. So you guys may have seen one version of that called a duckbill mask. Duckbill mask is a disposable version of an N95. And so basically everyone going in there should be wearing it the entire time. Remember, this bacillus is so small it can float for hours in a room. So we have to put them in a very specific type of airflow, a negative airflow room that has what we call an anteroom. And during that, inside that room where the client is, your book says 6 air exchanges per minute. That's a misprint. There's 6 air exchanges per hour. 6 air exchanges per minute, that patient would be living inside the backwash or the backflow of an airline jet. Okay? If you replace every cubic inch in a room 6 times a minute, there would be a roar from the fan that was sucking the air past that person. In fact, everything on their table would probably be sucked up to the intake or whatever, and it'd be crazy. Okay, so this is the correct information in case you prepped a prep guide from your book. HEPA filter, just like we talked about for the asthma patient, we want to kill this organism. We don't want to send it out into the world. However, it is not considered a violation of any kind of law if it is, if that air is exhausted outside the building. Okay? So never take your morning run or morning walk outside a hospital, especially their airborne room. If you see that little exhaust fan on the side of the wall, run. That's a bad place to take your morning run, okay? Ultraviolet light. Although this organism is very resilient, it doesn't like sunshine. And so those people, even though they're tired and exhausted, they need their blinds open so that anything that's settling on their bedside table, their linens or whatever, is killed by our friend, the sun. Okay? Contact list. This is what I was talking about a while ago. Anybody who has had close, repeated contact with this person really ought to be screened so they could be potentially treated as well. Let's nip this in the bud before it goes to the daycare center or the elementary school or even the Walmart. Yes, even TB bacillus travels to Walmart. Monthly groceries or something. Monitor compliance by referral both to a health department as well as to a home health agency for those who need that type of follow-up. Teaching and health promotion. What do we want to teach these people? I've probably said this 3 times. It's valuable information. They've got to complete that drug regimen exactly as it was prescribed, even though the side effects are unpleasant sometimes. And then we got to promote that nutrition. So they need more calories, more protein. They need adequate vitamins, B vitamins and C for their immune system. And then make sure they know those tyramine and histamine foods to avoid. And then anybody who is a high-risk group, so those high-risk groups we talked about, really should have their skin tested every year to make sure they haven't been exposed so that they can be caught quickly. But for those who already have TB, so in other words, they are what we call a converter when it comes to their skin test. So like I was labeled as a converter at that one point. I'd been negative for many years, and then all of a sudden I was positive. That's a converter. Then those people who don't have active disease, they have dormant TB. So they have been exposed, but they don't have an active infection. So they need to know the signs and symptoms so that when it does become active, they can revisit with their doctor about getting on treatment. Okay? And then I've listed those things that are most important for them to remember. Because remember that great big long list of signs and symptoms? Too much. Give them 3 or 4 things and they can possibly remember it. Okay? And then my last slide there on culture and spirituality. Recognize that there are certain traditions of Native American groups where they share ceremonial pipes during some of their religious ceremonies. That puts them at risk for spreading TB. It also, because of the smoking component, puts them at risk for COPD over time as well. And then recognize that any chronic debilitating illness can cause spiritual distress for any client. They often go through the steps of grieving when they have a chronic respiratory issue or any chronic illness. And so they may be experiencing bargaining, blaming, they may be evaluating the quality of their life or their life decisions, and they need some support. Just as I mentioned when we did the soda straw thing, they don't really need condemnation from us, they need support. All right? So any questions on any of that? Okay, if my coworkers will pass out that handout real quick, I'll give them 10 minutes to work on that. They can work in groups up to 3, no more than 3. And I will explain it as soon as we get it passed out because it's not entirely self-explanatory.